Hi, welcome to the second virtual preceptorship in male infertility. My name is Matt Coward. I'm the Director of Male Reproductive Medicine and Surgery at Atlantic Reproductive Medicine Specialists in Raleigh, North Carolina, and I'm also an adjunct professor of urology at the University of North Carolina. This talk is entitled Male Reproductive Anatomy and How It Relates to Sperm Retrieval Techniques. These are my disclosures. The objective of this talk is really to understand the rationale and the anatomy for why a reproductive urologist performs certain types of sperm retrievals. There are a number of indications for sperm retrieval. Primarily, it's azoospermia or aspermia. Azoospermia is when there's two semen samples that show no sperm in the ejaculate after centrifugation and examination of the centrifuge pellet. So aspermia, which is separate and different, aspermia is when there's no ejaculate at all or no semen to examine. So either one of these conditions can be present from obstruction or disorders of sperm delivery or spermatogenic failure. So obstruction can occur anywhere from the efferent ducts to the urethral meatus. The sperm delivery disorders from such conditions as erectile dysfunction or ejaculatory disorders have many different causes, which include retrograde ejaculation as well as neurogenic anejaculation. And then there's spermatogenic failure, which involve both testicular and pretesticular etiologies. The testicular are the more common, and these involve Sertoli cell only syndrome, genetic disorders, as well as about 50% of the time they're idiopathic. And then there's pretesticular causes of spermatogenic failure. We're not going to talk much about these. These are medically treatable causes of azoospermia, but this can include pituitary failure, such as from Kallman syndrome, hypogonadotropic hypogonadism, as well as from prior testosterone or anabolic steroid use. In addition to azoospermia or aspermia, other indications for sperm retrieval include situations where a patient has high DNA fragmentation and prior IVF failure. I'm not going to talk a whole lot about that, except for the anatomical considerations as we consider which type of sperm retrieval we might approach. So there are a number of goals for successful sperm retrieval. We'd like to get the highest quality sperm, the highest quantity sperm. And that allows us to bank the sperm and or use it fresh. The other goals include we want the least invasive approach as possible, as well as the lowest cost and lowest risk to the patient. There's other considerations for a successful sperm retrieval, and these include the training of the urologist or the training of the surgeon, the equipment available to the surgeon, that can involve where it's being done, such as whether it's being done in a urology clinic or urology office, in an operating room somewhere, or if it's being done on site in the fertility clinic. The support staff also play a role as far as their training goes. This includes the availability and accessibility of the andrologist and embryologist. The timing of the procedure is an important consideration, and so that's whether this is being done prior to the IVF cycle or end cycle, and then fresh versus frozen, which I'm not going to talk really much about, but are other considerations as to which approach we might take. The most important consideration really is the patient factors. So the patient factors are really based on the patient's anatomy, and so this slide here just shows a list of examples. And by the end of the talk, hopefully you'll understand why we might consider what we're going to discuss here on this slide. But for a patient with retrograde ejaculation, we can get sperm straight out of the bladder from a bladder sperm retrieval. And that can be a voided sample or a catheterized sample. For a patient with anejaculation, we would consider probably first electroejaculation or penile vibratory stimulation. For a patient with ejaculatory duct obstruction, there's a number of approaches that would work for a patient with this condition, but we might consider a seminal vesicle aspirate. For a patient with inguinal obstruction, such as from a prior hernia repair, those patients are going to have good sperm in the vas deferens, just proximal to that obstruction. So a vasal aspiration, which can be done through a no scalpel vasectomy technique, can get to the vas fairly easily and can get a sperm sample out of the vas from a patient with inguinal obstruction. When a patient has epididymal obstruction, and this is one of the more common scenarios, such as a patient with elective vasectomy or congenital bilateral absence of the vas deferens, we might approach things as an epididymal sperm retrieval with either a MESA or a PESA. And I'll discuss what these different sperm retrievals actually are later in the talk. Then there's high DNA fragmentation scenario. That's a patient who's not obstructed actually, and that's a patient who we might go after testicular sperm with a testicular sperm extraction called a TESI or an aspirate called a TESA. And then lastly, in patients with non-obstructive azoospermia who have no blockage, but very, very poor, very low sperm production, those patients need a microdissection testicular sperm extraction or a micro-TESI. In order to understand all of this, we really have to go back to the patient's anatomy again. So the next few slides are going to be male reproductive anatomy 101. Starting with the testis or the testicle. The mean testicular volume is 18 to 22 cc's for an adult. On average is about 20 cc's. There are 10 to 15 tubules called seminiferous tubules, which are divided by fibrous septa. And each seminiferous tubule drains into the reedy testis, which is kind of like the river delta here at the hilum of the testicle. From the reedy testis, the sperm then drain through the efferent ducts, which are shown here, into the head of the epididymis or the caput of the epididymis. From there, the sperm travel through the epididymis, through the mid-pole of the epididymis called the corpus, and then the cauda epididymis, before it enters the convoluted vas deferens and then the straight portion of the vas deferens. 80% of testis volume is made up of seminiferous epithelium. So the seminiferous tubules are a stratified epithelium, also known as seminiferous epithelium, and they contain both germ cells and Sertoli cells. So the germ cells are the spermatocytes and the spermatids, and the Sertoli cells line the basement membrane. These are large cells that nourish the germ cells through spermatogenesis. This is invested, the tubule is invested by a cell layer of myoid cells. And in the interstitium are the Leydig cells, which secrete testosterone. Germ cells move inward from the basement membrane towards the lumen, which is here throughout spermatogenesis. So spermatogenesis is depicted here on this slide. First, we have the testis, which is here, comprised of seminiferous tubules, draining each towards the reedy testis, and again through the efferent ducts into the epididymis. The seminiferous tubules house the Sertoli cells, the developing germ cells, and the Leydig cells. Spermatozoa formed in the testis enter the caput epididymis, progress towards the mid portion of the epididymis, and finally reaching the tail of the epididymis, during which time they undergo maturation processes necessary for them to acquire important functions, including progressive motility as well as capacitation or ability to fertilize an egg. Here is a expanded diagram of a seminiferous tubule showing the Sertoli cell and the developing germ cells. The spermatogonia here at the bottom, the basement membrane. These are the stem cells, and they're at the base of the tubule. And the spermatogonia develop into spermatocytes, which are diploid or 2N, and then haploid spermatocytes, and then finally the spermatids. In the tubule, the Sertoli cells intimately associate with the germ cells, and in fact, it's known that each Sertoli cell can support up to 40 to 50 germ cells. Spermatogenesis is the production of germ cells. This involves both mitosis and meiosis. The mitotic divisions of the spermatogonia from the 2N to spermatogonia to the spermatocytes is seen here. And then the meiotic divisions of spermatocytes to haploid spermatids are seen here. From there, the spermatids mature into spermatozoa. So overall, the task here for spermatogenesis is to convert spermatogonia, which are undifferentiated stem cells, into spermatozoa, which are highly differentiated haploid cells. Again, we see here spermatogenesis and sperm transport as the two areas of focus for this talk. Number one is the spermatogenesis, which occurs in the seminiferous tubules within the testicle. And then there's everything else, which is the sperm transport. So as the sperm head up the vas deferens, from the scrotal vas deferens to the inguinal vas deferens, around and behind the bladder, connecting with the seminal vesicle to the ejaculatory duct, and then out the urethra. So I'm going to go in through more detail through this sperm transport. The epididymis is a structure posterior lateral to the testis, connected to the testicle by the efferent ducts. And there's three parts of the epididymis: the head, the body, and the tail. And there's a central role in the epididymis in sperm maturation, which is progressive motility and the fertilizing capacity or capacitation of the sperm, which is gained through the maturation in the epididymis. Transit time in the epididymis is 10 to 12 days. Once the sperm leaves the epididymis, it moves into the vas deferens. First, the convoluted portion of the vas deferens, and then the straight portion of the vas deferens. This is a long 30-centimeter tubular structure which connects the tail of the epididymis to all the way to the ejaculatory ducts. It's a muscular structure. Contraction with ejaculation propels the sperm forward into the posterior urethra. You can see a histologic cross-section of the vas deferens here, showing just how thick the muscular layers are. In this image, we can see what the vas deferens looks like during a vasectomy. You can see it's a very small tubule. You can see the surgeon's finger here. It's a very tiny tube, which is not visible on scrotal ultrasound because of its small size. The seminal vesicles are paired structures which sit behind the prostate and underneath the bladder. They're 6 centimeters in length. So this is a seminal vesicle here, the right seminal vesicle, and here is the left seminal vesicle. They join with the vas deferens. So the vas deferens comes over the ureter, and then it dilates to what's called the ampulla of the vas deferens. And then the ampulla of the vas deferens and the seminal vesicles, they come together down here at the ejaculatory ducts. Note that the seminal vesicles do not contain sperm. They only contain seminal fluid. And the seminal vesicles produce 70% of the ejaculatory volume in the male. This is an alkaline fluid, which is rich in fructose. The pH of this fluid is 7.4 to 7.8. And so when we have an ejaculatory duct obstruction, usually we're getting obstruction of the seminal vesicles. So we see very low semen volume with ejaculatory duct obstruction. Another good example, which is helpful to remember, is that in men with CBAVD, congenital bilateral absence of the vas deferens, which I'll discuss later, they don't have seminal vesicles either. And so without that seminal vesicle, they're only getting fluid from the prostate, which is an acidic fluid. So you get a lower volume acidic ejaculate in men with CBAVD. The ejaculatory ducts are better seen here in this cross section. So the seminal vesicle comes in with the vas deferens, which is also, it's not pictured here, but comes in, and there's a confluence here of the seminal vesicle and the vas deferens right here at the ejaculatory duct. And the structure, as this is seen cystoscopically, is called the virumontanum. So this is a cystoscopic view of the inside of the urethra. With the camera would be sitting right here, looking towards the bladder. So we have the tip of the camera sitting right here, looking at the virumontanum. So this is a little bump. It's a little ridge in the center of the prostate, which is where the ejaculatory duct is. This virumontanum at the ejaculatory duct prevents the reflux of urine back into the vas deferens and the seminal vesicle. The prostate, which is seen here, so this is the two lateral prostate lobes. The prostate is a gland that secretes an acidic fluid, which contributes about 20% of the ejaculate fluid. And this is important for liquefaction of the semen. So the prostate makes a protein called PSA, prostate-specific antigen, which is also incidentally the blood test. It's measured in the blood, and when an elevated PSA level can indicate that a patient has prostate cancer. It also can be elevated in inflammatory conditions of the prostate. But the purpose of that PSA is that it liquefies the semen. And so in men with obstruction here, we don't see as good of liquefaction. So obstructive azoospermia is going to be the next topic here. So now that we've covered the basic anatomy, let's change gears. So we're going to talk about the obstructive azoospermia in more detail. And you can think about this in a couple of different ways. First, by anatomy, which is this slide, and then the next slide, you can think about obstructive azoospermia as either being congenital or acquired. So as we think about it by anatomy, start all the way back within the testicle. You can have obstruction at the seminiferous tubule, at the level of seminiferous tubules, and an example of that would be a male patient with a history of congenital adrenal hyperplasia who's developed adrenal arrests within the testicle, which can obstruct the seminiferous tubules. The epididymal obstruction is one of the most common sources of obstruction. The epididymis can be obstructed by prior surgery, infection. There's congenital obstruction, causes of obstruction, and then spermatoceles. The scrotal vas deferens can be obstructed from prior elective vasectomy or congenital bilateral abscess of the vas deferens. Inguinal vas deferens can be obstructed from hernia repairs or orchidopexies. And then the ejaculatory duct can be obstructed from prostate cysts, Mullerian duct remnants, strictures from prior trauma or infection. And then the outflow tract, the urethra, can have obstruction there from prior sexually transmitted infection resulting in a urethral stricture. And then lastly would be an obstruction at the very tip of the foreskin, where the foreskin is tight over the glands that can trap the semen inside of the foreskin, resulting in aspermia. So as we change gear, thinking about from an anatomy standpoint to whether this is a congenital versus acquired standpoint, we can think about obstructive azoospermia in this way. Congenital obstructive azoospermia etiologies include ejaculatory duct obstruction, which can be from a Mullerian duct remnant, CBAVD, which can be from a CFTR mutation or a Wolffian duct disorder, and then lastly, idiopathic epididymal obstruction as well. Acquired causes of obstructive azoospermia can be from infection, trauma, or iatrogenic causes. So infection from such problems such as sexually transmitted infection or urinary tract infection. This can result in ejaculatory duct obstruction, basal obstruction, or epididymal obstruction. Essentially, anywhere along the male reproductive path can have a blockage from infection, trauma, or injury. And then there's iatrogenic causes such as from instrumentation, such as from prior cystoscopic or ureteroscopic, endoscopic urological procedures. Then there's bilateral inguinal surgery, such as hernia repair, orchidopexy, as well as prostatectomy. And then lastly, the most common acquired cause of obstructive azoospermia would be elective vasectomy. A third of azoospermia is obstructive. I like this table just because it shows us that 2/3 of the etiologies of azoospermia are non-obstructive, and about 1/3 are obstructive, with the most common cause being a CF mutation or cystic fibrosis mutation. So going back to the anatomy again, where are these primary sites of obstruction that we're going to discuss? So the ejaculatory duct, the inguinal vas, the scrotal vas deferens, and then the epididymis. And I'll go through each of these, starting with the epididymis. So epididymal obstruction. This can result from elective vasectomy, which is the most common, congenital bilateral abscess of the vas deferens, which is the most common congenital cause, and then prior inflammatory conditions such as prior sexually transmitted infections or injuries, and then lastly, idiopathic congenital epididymal obstruction as well. This image here is from a patient with congenital bilateral abscess of the vas. So what is CBAVD? So this is a condition which is quite prevalent. About 1% of all infertile men will have congenital bilateral abscess of the vas. 25 to 50% of men with obstructive azoospermia will have CBAVD. So this is the most common cause of obstructive azoospermia other than elective vasectomy. And the reason that people develop this is most commonly from cystic fibrosis mutation. So about 80% of men with CBAVD harbor a CFTR mutation. And then among those who don't, those are mutations in yet to be identified genes involved in Wolffian ductal development. And those men can often have renal anomalies as well. And so what happens in a patient with CBAVD? They don't develop this portion of the vas. So they don't develop the vas as well as this portion of the epididymis. So what they're left with is a very small head of the epididymis, sometimes non-existent, but most of the time there's a small nubbin of a head of the epididymis. So we go from this picture to this picture when a patient has CBAVD. A common cause of inguinal obstruction would be a patient with a prior prostatectomy. We're seeing this more commonly now among men who are delaying paternity or men who are remarried who have a prior history of prostate cancer and a prostatectomy. Prostate cancer is being diagnosed in younger and younger men and being treated with prostatectomy. And you can see here the vas deferens has already been transected. And so this is a very radical procedure, but certainly we see transection of the vas deferens during a prostatectomy. What about inguinal obstruction? So during an inguinal hernia repair, the surgeon takes a piece of mesh, cuts out what's called a keyhole. So they make a cut here and with a little hole cut out, and then that goes and is wrapped around the spermatic cord, which sits like this in the mesh. And so you can see here that this mesh surrounds the spermatic cord, and this can result in an entrapment of the cord or mesh erosion, which can result in basal obstruction in the groin. Ejaculatory duct obstruction, again, can result from stones or cysts. These can be congenital or acquired. Acquired causes of ejaculatory stenosis might be a prior sexually transmitted infection, although the most common cause of ejaculatory duct obstruction are congenital. And then there's the sperm delivery issues, which include erectile and ejaculatory disorders. So for erectile dysfunction, this can be organic. We can see erectile dysfunction after radical pelvic surgery or radiation, as well as neurogenic erectile dysfunction, such as what we might see with diabetes. Retrograde ejaculation is another common sperm delivery disorder. This can be seen more commonly in older men, so men with enlarged prostate or BPH, that stands for benign prostatic hyperplasia. And any man with BPH who's taking prostate medicine, prostate medications, including alpha blockers, can result in retrograde ejaculation as a side effect. And then the most common cause of retrograde ejaculation in younger men is going to be undiagnosed and severe diabetes. Not necessarily undiagnosed, but we can say severe uncontrolled diabetes will result in ejaculatory disorders. And then there's anejaculation, which can be psychogenic or neurogenic. I'll go through that more in detail in a moment. So from where can we get sperm during a sperm retrieval? Well, basically anywhere. So we can get it from the testicle. We can get it from the epididymis. We can get it from the vas deferens. We can get sperm directly out of the seminal vesicle. We can get sperm out of the bladder. And then obviously we get sperm out of the semen. It wouldn't need us if we can get sperm out of the semen though. So So these are the areas of where sperm retrievals can occur anatomically. In the next few slides, I'm going to go through the different sperm retrieval techniques. And first, we'll start with the techniques that are available for obstructive azoospermia. So these techniques are alphabet soup. They're all 4-letter acronyms. They include PESA, TESA, MESA, and TESI. I'll explain what each of these are. First, I'd like to say that any sperm retrieval will work for a patient with obstructive azoospermia. So it really comes down to getting optimal sperm, and that depends on many factors. So the first would be considering whether we go for a percutaneous versus an open approach. The decision on percutaneous versus open is going to have to do with the setting, the equipment available, the goals of the patient, and those goals might include costs or desire to bank sperm ahead of the IVF cycle. And then in addition to the considerations of percutaneous versus open, we have the consideration of testicular versus epididymal sperm. And that consideration is a bit more complex in the decision because we're thinking about the etiology, the location of the obstruction, the experience of the surgeon, as well as the lab's preferences and whether they'd like to work with testicular sperm versus epididymal sperm. In a classic obstructive azoospermia scenario, such as elective vasectomy, you could do any of these. Any of these are going to be effective for a patient with a vasectomy. So first, testicular sperm aspiration, or TESA. Advantages of TESA are that it can be done with local anesthesia only. It can be performed at short notice. There's no special training required. There's minimal equipment. It involves a very quick recovery and is a low cost to the patient. Downsides can include that there's a very small amount of tissue retrieved, which may or may not be enough for cryopreservation. So it's often done on the day of egg retrieval. A TESA can be called a rescue TESA when it's done after a failed PESA, which I'll talk about in a second. For a TESA, I like to use a Kamiko syringe, a pistol syringe, which is illustrated here in the picture. There are other techniques which can be implemented, which involve different types of needle aspirates. The sperm retrieval rate with a TESA is between 95 and 99%. If this fails and the procedure is being done fresh, the surgeon will need to be ready to convert to a TESI, or else we're going to have to bank eggs. Next would be a PESA, which is a percutaneous epididymal sperm aspirate. This is done with a butterfly needle, which is passed directly into the head of the epididymis. Similarly, only local anesthesia is needed, no special equipment. The sperm retrieval rate is only about 90% with a PESA, so you need to be ready with a backup plan, such as a TESA or a TESI. The PESA is typically done fresh, so done typically on the morning of egg retrieval. PESA does have a higher risk of hematoma, somewhere in the 1 to 3% range. I don't personally do a lot of PESA, as I opt for epididymal sperm using an open approach, which is called a MESA, which I'll talk about in a second. Next is the TESI. That stands for testicular sperm extraction, also known as a testicular biopsy, synonymous with the testicular biopsy. This is really the gold standard. It can be done with local anesthesia only, but can also be done with sedation. The sperm retrieval rate with a TESI is going to be the highest. It should be 100% in men with obstruction, although the amount of sperm isn't quite as high as with the epididymal approaches. No special equipment's required for a TESI. The procedure can be done after just general urology training. The sample from a TESI can be sent for both pathology or cryopreservation. So we're able to see tissue architecture with a TESI, which is a nice part of a nice advantage to a TESI. The downside is that the recovery is going to be slightly longer than with the percutaneous approaches, although it's still only going to be about 3 to 4 days. Some surgeons are going to have concerns about epididymal sperm containing high reactive oxygen species. That's not a concern that I share, but that is something that you may hear. And if that's a concern, then testicular sperm is going to be the way to go. Another concern with TESE is that if the sample quality isn't great, testicular sperm doesn't always thaw well, and so that shouldn't be a problem with patients with obstructive azoospermia, but in a poor quality TESE sample, that can be a concern. And then lastly is the MESA, which stands for microsurgical epididymal sperm aspirate. This is the most complex of all these procedures. It does require a microscope, and typically this is only done by fellowship-trained reproductive urologists. It's often done with general anesthesia, and which can make it more costly, although there's a very high sperm retrieval rate, near 100%, and we get the highest quality sperm and the highest quantity sperm with a MESA, which allows for multiple vials of high quality sperm to be banked. I prefer a MESA that looks like this. So rather than a full exposure, we do this in the clinic here. We make a small keyhole incision and actually deliver the head of the epididymis out. This is a patient with congenital bilateral abscess of the vas. I throw a 3-0-chromic suture into the head of the epididymis as a stay suture. You can also see the eyelid retractor, which is being used to hold open this tiny incision. So it's about a 1.5 centimeter incision. And then you see my non-dominant hand here holding the epididymis, and then with the dominant hand coming in with the ophthalmic knife to make a small puncture. And so when you're looking at it under a microscope, or even loop magnification can be used for this, you can see the tubules look different. In this case, either one of these might be better sperm. It would really depend on the patient. But you see these blood vessels here, which you can't avoid these during a percutaneous approach, but during a open approach, you can see the blood vessels and avoid those. You can make small punctures. Typically, I'll make 3 or 4 different sites in order to find the best sperm. So we're sampling. We take a little bit out with this angiocatheter and put it on a slide, which allows us in real time to get the best possible sperm sample. At the end, you see it's a very tiny little incision, which is closed here in the last image. So what about with anejaculation? What about if a patient cannot produce a semen sample? So this would be patients such as adolescents, patients with hormone abnormalities, nerve damage, spinal cord injured patients would be the most common. Men who have anejaculation, almost uniformly, all patients with spinal cord injury have anejaculation. And this can be approached through these different assistive ejaculatory techniques, including penile vibratory stimulation, electroejaculation, or if those fail, we can turn to a surgical sperm extraction as well. The penile vibratory stimulation is really the first-line treatment for men with idiopathic anejaculation or neurogenic anejaculation when they have high spinal cord lesions. So this has been studied most extensively in spinal cord injured patients, and PVS is most effective in men with lesions above T10. It's a simple, non-invasive, it's cost-effective, and for men with spinal cord injury, it's often successful in about 75% of those men, particularly in men with high spinal cord lesions. For men with lower spinal cord lesions or other patients with neurogenic anejaculation, there's electroejaculation. This is done with a device called a Seeger electroejaculator. The small probe is positioned just over the prostate. This is done with anesthesia in men who are sensate, and can be done in men with spinal cord injuries. It can be done awake. This is a gold standard treatment, which obtains an ejaculate in nearly 100% of men with neurogenic anejaculation, although about 10% of the time it's going to be primarily non-motile sperm. So only about 90% of men who undergo electroejaculation will have success in retrieving motile sperm for cryopreservation. This can also be done in adolescent patients that we would typically only do in post-pubertal patients with a known intact sperm ductal system, as well as an examined hormone profile suggesting normal spermatogenesis. And what I mean by that is they would need to be older than 13 years of age, 10 or stage 3, and with testis size greater than 12 cc's, also with a normal hormone profile suggesting normal spermatogenesis as well. Moving on from obstruction to now non-obstructive azoospermia. So ICSI was first described in the early 1990s by Palermo, where an injection of a single sperm into an oocyte enable men to be biologic fathers despite severe testicular failure, damage, or obstruction. And shortly after shortly after ICSI was developed, Peter Schlegel described microtessie in the late 1990s, and this is really popularized in the mid-2000s. So microtessie, in my opinion, in the 21st century, microtessie represents the greatest advancement in treatment of male factor infertility and arguably in all of reproductive medicine. There are a number of genetic etiologies of non-obstructive azoospermia. These include chromosomal numerical defects that include Klinefelter syndrome, as well as other aneuploidies, chromosomal translocations, and then Y chromosome microdeletions. It's important that for men with non-obstructive azoospermia, so this has been with testicular atrophy as well as high FSH levels, it's important that these men undergo karyotype and Y chromosome microdeletion testing. I'm not getting into the diagnosis of non-obstructive versus obstructive azoospermia in any more detail, but for the purposes of this talk, when a patient has non-obstructive azoospermia, they really need to be counseled towards a microtessie and no other type of sperm retrieval. A microtessie is a microdissection testicular sperm extraction, and this is where we use an operating microscope. The testis is bivalved, so the incision comes across the front of the testicle here, and then the testicle is clamshelled open or bivalved. And I prefer using a mapping technique where I make sure that I biopsy and search in each quadrant, each of 12 quadrants of the testicle. But what we're looking for here are dilated tubules that stand out around a field of other smaller, more wispy tubules. This is a really nice example here. So this white arrow points to this little wispy tubule, so this thin white tubule, and then you see this really fat tubule here right next to it, and you can see the difference in width of this tubule to this tubule. So this is a tubule that's going to contain sperm on a microtessie. And this allows for focally targeted excision, higher sperm retrieval rates. We see less scar tissue with this technique. It preserves vasculature and preserves testicular function and testosterone production better than in taking very large testicular biopsies for these men. We see a much higher sperm retrieval rate, which approach about 50% on average, compared with standard tessie, which is more like 20%. So in conclusion for this talk, understanding male reproductive anatomy and etiology of azoospermia or aspermia are critical to determining the best sperm retrieval technique. Any sperm source, and that includes open or percutaneous or epididymal versus testicular or fresh or frozen, which I didn't go into, but any sperm source from a patient with most etiologies of obstructive azoospermia can be effective. However, the most optimal samples actually require planning and understanding of the anatomy. There are many nuanced technical differences between these procedures, which may yield better samples for particular patients when the patient factors are taken into account. Men with erectile dysfunction or ejaculatory disorders or other types of sperm delivery disorders are good candidates for neurostimulatory methods of assistive ejaculation, such as electroejaculation. And then lastly, men with non-obstructive azoospermia should be recommended for microtessie and no other type of sperm retrieval. So thank you so much for your attention during this lecture, and I hope you enjoy the rest of the course.